So I'm going to share my screen real quick. So this is what we got coming up next week. We'll have Dr. Hahn, and she's going to talk about inpatient treatment and detox. And so that's what she'll be talking about. And then I mentioned last time the parent-child assistance program, but Dr. Meyer, she'll be talking about the last.
So where would you say you're at now with this? So if we're using still our same, kind of rating scale of a workout, right? One end of it being you're not on the machine at all, and the other end being you're ending the workout. Where would you say you're at with that right
now? Yeah, Suzanne, I think you need to mute yourself. All right, Dr. Fink is on. Dr. Fink, we're going to let you do introductions today and take it away. We're really excited about talk on motivational interview, and of course, a very important part of substance abuse treatment. So here we go.
Great, thank you.
And what helps you be there and not even knowing what the workout is?
Kelsey, can you mute Susanna? I'm so happy to introduce Dr. Hedema today. She's been a long time colleague of mine. We started graduate school together, so I've known her for a long time. She's a very esteemed colleague, excellent scientist and clinician.
Okay.
And she is currently the
Are there times that you feel like you're doing better with it
clinical director and director of training, education, and development program at LifeStance Health, which is a national outpatient mental health care provider. She's a licensed clinical psychologist with a background in research on the development, evaluation, and dissemination of brief behavioral health interventions in medical settings. She's a member of the Motivational Interviewing Network of Trainers, and much of her work integrates this approach. Dr. Hedema's work has focused on the scholarship of teaching and learning, and she has supported educators from a variety of settings in using evidence-based curriculum design techniques to meet the needs of learners. As a former professor with tenure at the Department of Family and Community Medicine at the University of New Mexico, Dr. Hedema was the principal investigator of several large federally funded grants investigating the impact of brief motivational interviewing on an array of behaviors, including unintended pregnancy, unhealthy alcohol use, drug use, and medication adherence. And please just join me today in welcoming Dr. Hedema, and it's our pleasure to have you today. Thank you. And I'll turn it over to you.
Thanks, Dr. Fink. We miss you here in Albuquerque, but I'm sure your colleagues are happy to have you there. Thanks for having me, everybody. I'm happy to be here. I am going to share my slides. Are those showing up okay? You know, it's weird when I go to full screen, it keeps not wanting me to do that. Did they show up for a second and then disappear?
Yes.
So I'll just take a different approach. Do they show now? Okay. So most of us, I think, when we think about motivational interviewing, are most likely to think of kind of the patient-centered, client-centered, relational elements of motivational interviewing, where we're empathic and non-judgmental and collaborative with our patients. And I think there's a lot of research to suggest that that's kind of the main ingredient of motivational interviewing. And in a lot of ways, that's a common factor that drives many of our interventions with patients. I find it we're less likely to think of another element of motivational interviewing, which might come a little less intuitively to many of us, and that's this more technical aspect of evocation, or strategically drawing out and reinforcing change talk. And in our current models of motivational interviewing, it's really both of those things combined. So the relational elements, which aren't necessarily unique to motivational interviewing, but using the skills, those relational skills, to strategically draw out motivational speech. And so that's going to be the focus of our presentation today. So by the end of this session, you should be able to identify change talk when you hear it. You'll see, if you don't already know, that sometimes it can be easy to miss change talk in our interactions with patients, and just even having a good ear for it can, at least for me, dramatically impact what I'm likely to say next to my clients, and describe some strategies for responding to change talk or drawing out change talk if it's not being offered. So we use this term evocation in motivational interviewing. We kind of like fancy terms, but this is a term we use in our day-to-day language. And when we're thinking about it in motivational interviewing, we're just substituting motivation for change everywhere. So we're trying to call up or produce people's motivations for change. And in our case today, their motivations to either reduce or stop unhealthy alcohol or drug use. We want to draw forth their motivations to change, to cause them to appear. And we know from our process research on when clinicians speak with patients using any style, including motivational interviewing, that what we say and do as a clinician can dramatically impact how much patients verbalize their motivations for wanting to change. Some basic things that we can do are taking that patient-centered stance and being non-judgmental and collaborative, and that makes people likely feel safe to be able to express some of their desires to change. But there's also some more technical ways that we can do that, and we'll look at them today. When we think about whether we're wanting to draw out change talk as clinicians, motivational interviewing model encourages us to be familiar with this concept of equipoise. So equipoise is where we're just listening to our patients. We're seeking to understand where they're coming from, to understand both sides of ambivalence they might have about a behavior change, but we're not doing anything to kind of strategically steer them in one direction or another. So Rogerian or client-centered counseling uses more of this approach. On the other hand, there's strategic evocation, and this is really what motivational interviewing was developed to do, to strategically draw out motivation. So it's important to ask yourself when you're working with a patient, do you want to proceed strategically to steer the patient in one direction or another, or maintain equipoise? It's a little easier when it comes to substance use, as it's often the case that when people are using alcohol or drugs, it's having a negative impact on their health or their goals and values. But often when we're thinking about clinical scenarios, there's some that we may encounter in a therapeutic context that we're going to want to have equipoise. So a woman deciding whether to have children or not might be one example, all the way down to something where most of us would probably agree that we want to be strategic if you're working with a person who's committed sexual offenses, who's contemplating new victims. And a lot of our substance use issues fall on this end of the spectrum. If you've read the 3rd edition of motivational interviewing or heard about it, they introduced these new concepts. Well, the concepts aren't new, but the labels are, called the 4 processes. And evocation kind of falls in these 4 processes. For me, in this edition, having these labels for these processes really helps me to think about my work with clients and what strategies I want to be using depending on where they are in their readiness to change. So at the foundation are these engaging skills where we're wanting to understand where the client's coming from, to use a lot of reflective listening and empathy to understand their unique situation, build trust, demonstrate to them that we're not going to judge them or tell them what to do. The next process is focus, and this is where we collaboratively work with the patient to identify what the focus of our work together is going to be. Some patients may come to us, presenting for issues related to substance use. Other times they may present for other things like, mental health symptoms, but substance use comes into focus. Then we have this process that we're going to be focusing on today called evoking. And that's where, once we know the focus, we're strategically seeking to help the patient talk about reasons why they might want to change. And eventually, if a patient resolves their ambivalence around change, then we collaboratively help them to plan. So the first step in mastering evocation is to even be able to recognize change talk in the first place. If you've done a lot of coding of sessions like Brandy and I have, so I find myself coding even radio commercials for change talk. But we have this acronym that helps us to remember basically that there's lots of different types of change talk, knowing that it can be easy to miss change talk, especially when you're working with patients who have really unhealthy behaviors and you're worried about them and they're ambivalent about change. And mixed in with the change talk are reasons why they can't or shouldn't or don't need to change. As clinicians who care about our patients, it's much easier to focus on those barriers to change than to actually hear the little pearls of motivation that are in there. So we love acronyms in motivational interviewing. We use one called Darn Cat to remember that there's lots of different types of change talk. So the desire, I want to have my kids back. I wish I was healthier. Some change talk can focus on our confidence or ability to be able to change. I quit using for 3 weeks once. We have reasons for wanting to change. Sometimes it's more this need to change. And then we have more action-oriented types of change talk. So I'm going to do this. I will cut back on my drinking. Sometimes it's more, I think I could do that. And then sometimes people are actually taking steps. Like I attended a 12-step meeting, for example. We use this analogy called the MI hill to talk about change talk. So as people are thinking about making a change, you often hear this preparatory change talk where you hear their desire, ability, reasons, and need to change. And we're kind of attending to the ratio of that amount of language to the flip side of the coin, why they don't want to, can't, don't need to, or won't change. It's usually pretty mixed up, but as people work across a session or across multiple sessions to think about their unhealthy behavior, you see this ratio kind of start to flip and then transition into this more mobilizing change talk where people are making commitments or taking steps. All of this kind of maps onto the stages of change, which many of you may be familiar with. There's a lot of parallels between the stages of change and motivational interviewing, but some important differences too. In stages of change, we kind of think of these readiness levels as being more inherent characteristics of the patients that we're working with. And there's the recommendation to match your strategy and your approach to where the patient is at on the stages of change, which motivational interviewing often also has. But in motivational interviewing, we see these stages as really, in many ways, being byproducts of the interaction between the clinician and the patient. So if you're faced with a patient and you don't take time to engage and collaboratively focus and instead try to prematurely plan, or definitely if you have a judgmental stance or give unsolicited advice, then you tend to see lots of counter change talk or sustained talk with people saying why they can't or don't need to or won't change. On the other hand, when we're empathic and attend to these relational issues and use some of the technical skills that we're going to look at in a minute, then you see a lot of motivational speech. So the same patient can look very different depending on the stance of the clinician that they're speaking with. And they've even done some really interesting like on-off designs where they'll have the same clinician be very directive and then very empathic and evoking and switch to a more directive stance. And as clinicians move in and out of those approaches, you can watch patient change talk go up and down aligned with the clinician's approach. So I thought we might pause for a second and do an exercise where we think about examples of change talk that you might hear from the patients that you work with. So I wonder in the chat if you might take a stab at just generating 2 or 3 examples of change talk that fall into these categories. So I might say that with the patients that I work with, a lot of my work is with patients who drink alcohol in an unhealthy way. So I might say a desire would be, I want to lose weight. So I entered that into the chat. I put it's a desire and then kind of what I might hear from a patient. So I'm going to pause for a minute and give everyone a couple minutes to think about examples of change talk you might hear from your patients. Nice. I want to be happy. I want to do the right thing to honor the donor. I don't like the way I feel. I want to be there for my kids. I'm attending AA. Love it. I want to quit using. Yes. Love it. You can start to split hairs quite a bit with some of this change language, and the process researchers do. There's even, like gain framed and loss framed language. So I love the Emily's, I know my life can be better as an example of a gain frame. Something could be better or different versus my life's going to suck if I keep this up, which is more of a loss frame. Thank you guys for those examples. Like I mentioned, it can be easy to miss change talk. It seems pretty straightforward, but when it's surrounded by sustained talk, just the way our minds work, especially as clinicians, we're tempted to attend to the sustained talk, and whatever we're attending to as clinicians, we're more likely to reflect or ask follow-up questions about, which then leads the patient to engage in more sustained talk instead of more change talk. So here's an example. You might have a patient that says, I'm feeling awful today. Last night I got totally wasted. I knew I wanted to drink, but I told myself I'd just have a few. As usual, a few turned into a lot. I wish I knew why that happens to me. I wound up getting totally wasted, which led to another huge fight with my girlfriend. I don't even remember exactly what happened, but I have flashes of an argument and woke up on the couch. Now she's not speaking to me. I love drinking and just checking out from the day, but I hate it when things like this happen. So if a patient presented to us, in many ways, kind of the gestalt of this is sustaining or counterchangey and concerning. But within it, there are examples of motivational speech. And there's some things in here which could probably be framed either as sustained talk or change talk. But do any of you see any motivational speech kind of shining through here? And if so, would you either unmute and share or enter it in the chat? Yeah, I wish I knew why that happens to me. So it's kind of a desire for something that would ultimately, facilitate the ultimate behavior change of drinking in a more controlled manner or not drinking. What else do you see in there that could be framed as change talk?
He says he says he hates it when things like that happen.
Yes, I hate it when things like that happen. All the consequences in some way. I mean, he doesn't remember what happened. He has flashes of an argument. His girlfriend's not speaking to him. Those in many ways could all be reasons for change. So when we think about what we might want to say next in response to a patient who presents like this in the motivational interviewing model, we might differentially focus on those pieces of change talk. It's tempting. Well, okay. All of this is the byproduct of a lot of process research, which in very simple form shows that when we use these MI strategies, both the relational ones and some of the technical ones that we talk about, we're more likely to hear this preparatory change talk. Preparatory change talk predicts this more commitment language, and that predicts change. So when Brandy asked me if I wanted to come to present today, I said, yes, that sounds really fun. I think I can do it. I'll be there. And then I didn't send my slides until yesterday, but nonetheless, I showed up. There's not a perfect correlation between these things, but generally it's not rocket science. Most of us know this intuitively. The more we talk about why we want to do something, and especially when we commit to something, the more likely we are to do it. But upstream here, we know that we can have a big effect on that language. So motivational interviewing is really designed for patients who are ambivalent about making a change. And we use our skills to differentially focus on reasons for change. So what kinds of reasons for change do patients who misuse alcohol or drugs tend to have? We saw a lot of those in the chat. Oftentimes these things are having negative impacts on their important relationships. People don't like to feel like they're being controlled by cravings. People don't like a lot of the negative psychosocial consequences that they experience. But people also have a lot of reasons to stay the same. Maybe they enjoy the feeling of alcohol or drugs. Maybe when they use alcohol or drugs, their feelings of withdrawal are eliminated. Maybe they're using alcohol or drugs in part to help them manage mental health symptoms. So in many approaches, often the temptation is to ask people why they're using and what they get out of it. And in motivational interviewing, we're instead focusing on how things could be better or different. When we hear change talk in motivational interviewing, we're encouraged to differentially respond to it. So first, to be able to hear it, and then to use these core communication strategies to differentially respond. You've probably heard of the ORS techniques. These aren't unique to motivational interviewing. These are central to any good form of communication, but how they're used is kind of unique in motivational interviewing. So if you hear a piece of change talk, you might ask a person, tell me more about that. You could affirm somebody's change talk. You could reflect it, or you could give summaries to patients across your session that include these bouquets of change talk. So we're going to do an activity where we're going to listen to one of the greatest rock songs that's ever been written and played. I'm going to share screen and put the lyrics on the screen. And your job is to listen for change talk, just like you did in that paragraph that I shared earlier. So just note it in your head or jot it down. Your job is to listen for change talk. And there's lots of sustained talk in the song as well. Sorry, it's wanting me to give it special permissions to share my audio. Okay. I'm going to play it for 1 second and then make sure the audio works. Did the audio work? Okay.
Jane says, I'm done with Sergio. You treat me like a rag doll. She hides the television. Said I don't know him nothing about it. Oh, he come back again. Tell him we're right here for me. Oh, try again tomorrow. I'm gonna kick tomorrow. I'm gonna kick tomorrow. Jane says, have you seen my wig around? Hook and naked without it. She knows they all want her to go. But that's okay, man. She don't like them anyway. Jane says I'm going away to Spain when I get my money saved. Gonna start tomorrow. I'm gonna kick tomorrow. I'm gonna kick tomorrow. Well, she did, man, and she starts to cry. She take a swing, man. She can't help. She don't mean no harm. She just don't know what else to do about it. And Jane goes to the store at 8. She walks up on St. Andrews. She waits and gets her dinner there. She pulls her dinner from her pocket. Jane says I ain't never been in love. I don't know what it is. She only knows if someone wants her. I want 'em if they want me. I only know they want me.
Okay, so then there's a really awesome guitar solo, but it's probably not as aligned with our learning objectives. Can you see the lyrics? Is my screen sharing? Okay. So our first, let's take one example. I see that somebody entered into the chat that one example of change talk is I'm gonna start tomorrow. I'm gonna kick tomorrow. So what kind of change talk is that, would you guys say? Desire, ability, reason, need, commitment.
Desire.
Yeah, I'd put it more in the commitment. So she's saying, I'm gonna kick tomorrow. I'm gonna start tomorrow. It's not right this second, it's in the future, but nonetheless, I mean, that's a solid commitment. So if we were to respond to that using one of our ORS techniques, could someone think of an open-ended question that we could ask in response to "I'm gonna kick tomorrow" that might be likely to get more of that type of language?
How would that look for you when you start tomorrow?
Yeah, so tell me more about that. Like what's that gonna look like? How are you gonna do that? So there's kind of to me, there's two ways to respond to that. If we think if you have a patient and they're making a commitment and you really do think they're kind of ready to go, then yes, we would move into that kind of planning process. And like you said, ask them, tell me more about that. What would be the first step? What would be the second? If she says this every week and we think it's more, she wants to, but is having trouble actualizing it, then we might want to try to get more of that preparatory change talk. And we might ask just, why do you want to kick tomorrow? What are some reasons why it's important for you to stop using? What are some things, bad things about using that you don't like? What would be some good things that would happen if you did kick tomorrow? What strengths and resources do you have that'll help you to follow through with that plan? So those are all open-ended questions that we could ask in response to that. We could affirm it, you really know what you want. We could reflect it. What might be a reflection of "I'm going to kick tomorrow"?
You sound like you're ready to make a change.
Beautiful. You're ready to make a change.
I was well trained in graduate school.
Okay, beautiful. Okay, so what's another example of change talk that you hear in here? We'll run through that exercise with a few of them. "I'm done with Sergio." Yes, so this gets into that kind of equipoise situation. I'm inferring from the context here that this is probably, a relationship with some DV and not healthy, and that we would strategically want to respond to that. So what kind of change talk is "I'm done with Sergio"? Yeah, action or a commitment. I agree. And so if we wanted to ask an open-ended question that was designed to get more change talk or more motivational speech, and here the focus is about her, getting out of this unhealthy relationship, what's an open-ended question we could ask that would get more of that change talk? A good one is always just "why." If you ever hear change talk, tell me more about that. What do you think the results will be when you leave Sergio? And that's a great neutral open-ended question. In MI, we might make it even more strategic by saying, what are some good things that will happen when you leave Sergio? What are some bad things that might not happen if you get out of this relationship with Sergio? How will things be better or different if you're not in this situation? Yeah, and maybe even there's what happened with Sergio, but we could say, tell me some of the things about your relationship with Sergio that you don't like. So you're really being strategic to draw out this change language. You could affirm that you really value your own health. When you decide to do something, you follow through. We could reflect it. The reflection might be you're ready to be out of this unhealthy relationship. Nice. Okay, let's do one more. What's one more piece of change talk? I could I've done this exercise in so many trainings. I feel I could write a dissertation, like almost, yeah, there's a lot of examples. What's one more? All right, all right. Oh, yes, thank you, Brandy. Yeah, she's going away to Spain when she gets her money saved. So here she has this healthy, pro-social goal that is likely incongruent with her unhealthy substance use. And so what is this? Is this a desire, ability, reason, need? I think it's a good reason. So it's going to be hard to go to Spain if she continues using heroin, because she's not going to be able to save her money. So we could ask an open-ended question. Tell me more about that. Why do you want to go to Spain? You know, asking her to vision, what would it be like there? What are you looking forward to doing there? Anything she can do to talk more about this thing that is incongruent with her substance use is going to make it more salient. I kind of think of pieces of change talk on that scale of ambivalence, like they're little weights on the change side of ambivalence, but we can make the weights heavier by having people elaborate on them and talk about them more and interconnect them with other values in their lives. So the more that she thinks about and actualizes this trip to Spain, the heavier that motivator becomes on that scale of ambivalence. We could try and develop a discrepancy. So again, you're wanting to pull this out of the patient instead of telling it to them, but you might say, you know, how, if at all, does your heroin use impact your ability to save money for your trip to Spain? Giving them the opportunity to talk further about this reason. Thank you for doing that exercise. Any thoughts or questions about that? Okay. So we've talked about how to recognize change talk when we hear it. And you can see even with this song, I'm sure many of you have heard this song before. And to me, it was always just a sad song about a woman with a substance use disorder who likely wasn't gonna, you know, who probably said this every day. But with this new lens of looking for change talk, I hear it quite differently. And there's actually a lot of hope in here and room in here to leverage the direction of a conversation. Oftentimes when I do this exercise and I ask people to give an open-ended question in response to, I'm gonna quit tomorrow, someone offers up, why wouldn't you quit today? So that's an open-ended question, and it is in response to the change talk. But if you asked Jane, why not today? What is she going to say in response? She's going to tell us all the reasons why it's not practical to stop today, why maybe it's not, you know, that urgent of an issue. She's going to give us all the barriers to change, but it's the tempting question to ask because we're worried about her. So instead, we might say something like, tomorrow, why not next week? And then it seems counterintuitive, but you're getting all the reasons why she better hurry up and make the change. Sorry. So we've learned to recognize change talk. We've learned to respond to change talk with some of these core communication strategies, but there's also some things that we can do to draw out change talk. So one is just to use what we call evocative questions. So open-ended questions, the answer to which is change talk. It's kind of like Jeopardy. You have to train your mind to think like we just did with the why not today versus why not next week, to think about what the answer is going to be before you form the question. And you're wanting to form questions in a way that kind of corner the person into being compelled to offer whatever motivators they do have. So there are open-ended questions that map on pretty well to our different types of change talk. Why would you want to make this change? How might you go about it in order to succeed? Similar to that ability one, what strengths and resources do you have that might help you to make the change? What are some of the top reasons for you to make the change? How important is it? So what do you think you'll do? And if you've ever participated in an introduction to motivational interviewing workshop, one of the things that we often do at the beginning is just have people partner up. Each person thinks about a change they're thinking about making, and their partner asks them these questions. And you'd be amazed how far you can get in 5 minutes just by asking some strategically designed, evocative questions like this. A lot of you are probably familiar with the rulers that we use in motivational interviewing. So we could use these to assess readiness, confidence, importance. The idea is that if somebody is going to make a change, they have to think it's important to make the change, but they also have to believe that they can do it. And then readiness is, and it's important to do now or soon. So depending on where your patient is stuck, maybe they recognize that their alcohol use is totally having negative impacts on their life, but they've tried to cut down a lot and haven't been successful. And so it's really that confidence that you're wanting to build up. Then you might make your ruler using the confidence construct. So how confident are you in your ability to make a change on a scale from 1 to 10, where 1's not at all confident and 10 is like, you've got this, no problem. Sometimes people can feel a little awkward using these because they feel kind of scripty, and they can be kind of scripty. Patients don't tend to receive them that way. And you can weave in your own language. I found the more that I do these, the more second nature it becomes, and the more I can ask those evocative questions or do things that are structured like a ruler, naturally gets easier and easier. And then, since we are trying to elicit change talk, one, it's interesting to know where people are on these scales. That can be helpful to us as clinicians. But really, the main point of these rulers is to evoke change talk. So we ask this counterintuitive follow-up question: why are you at this score and not something lower? And that aligns with that same construct as, why don't you want to kick next week? Why tomorrow? You could also ask them what it would take to move them from one score to a higher score. They're kind of opposite sides of the same coin, but the goal is, using that Jeopardy technique, you're trying to give them cause to talk about why it is important. There's also lots of values card sorts out there. This one's available for free on the internet. Brandy and my former mentor made this. There's lots you can do with card sorts clinically. There's ones that are focused on values. There's ones that are specific to adolescents and kids. I've seen ones for patients with thought disorders. There's also strengths card sorts. So again, if you're trying to do more on the confidence side of things, you can ask people to think about their strengths. But in this values card sort, one way you can use it that's very consistent with the evocation process of motivational interviewing is to ask people to select some things that are important to them, maybe their top 3 values. Again, you could use a card sort for this, or you could just do it freestyle in conversation. But once you know what people's key values are, then you can seek to develop a discrepancy between their values and their unhealthy substance use using some of these open-ended questions. So if someone selected family or their kids, you use your ORS technique to understand more about why their family or kids are important to them, and then ask them to reflect on how, if at all, their substance use might impact that value. Roadmaps are one of my favorite things to do. In this structured activity, you can actually, that's about how good my drawing is on paper too, but you could have paper or you could just do it visually. So you say to your patient, okay, so, we're here today and you have some decisions to make about your alcohol use. So we're here kind of at the start of the road. And I wonder whether you might be able to kind of do a visioning exercise with me where we think about your life down two different paths. On one path, you cut down on your drinking or even quit. And on the other path, you keep drinking in the same way that you are today. So first, I'm wondering, what are some good things down the change path? How might things be better or different down the change path? And you listen and you reflect and you affirm and you ask for elaboration and you say what else, and you're just giving them the opportunity to talk about all the good things down the change road. And then how about down the non-change road? What are some bad things down that road that you want to avoid? And again, using your ORS techniques to ask for elaboration, to affirm and reflect. Some of you may be familiar with this decisional balance exercise where you ask people, what are the pros and cons of changing and what are the pros and cons of staying the same? In motivational interviewing, we're just doing 2 cells of that 2x2 matrix, the good things in changing and the bad things about not changing. In the context of doing that, patients will offer up counter change talk or sustained talk, and we just kind of let that go by. Oh, I just threw, this isn't substance use specific, but one of the applications of motivational interviewing that I've used is for unintended pregnancy. So in this intervention, we were working with adolescents and we evoked their reproductive life plan. So do you want to become pregnant or a parent in the next year? 99% of them said no. And then we asked them to think, if you stick with this reproductive plan, what are some of the good impacts it might have on constructs that we knew were important to them? Your employment, your independence, your partner, your family, your friends, your education. How about if you didn't stick with your plan and you had an unintended pregnancy? What bad effects would that have on these same constructs? So it's possible to create structured tools that really, these were quite robust conversations that could go on for like 10 minutes, just using ORS questions, thinking about this fork in the road. So I'm gonna stop share and just open it up to any thoughts, questions, ideas.
I have a question, or just at least a comment. I wonder, how often do you in MI use this? I think an old supervisor of mine said using it to like quote unquote blow out the extremes to elicit a certain response, especially if somebody doesn't want to come into therapy or want to be seen by you. And some of the advice was given was in the sense of so everything's going perfect in your life then, so you really don't need to see me. And just to see how that is that that wasn't something my supervisor made up, right? I'm sure that falls in line in some capacity.
Yes, and yeah, it's the same idea. If you have a patient who's ambivalent about engaging in treatment, you could offer the extreme or their substance use. There's literally nothing about your substance use that has ever caused even one little problem whatsoever. And the hope when using a strategy like that is that if there is any underlying ambivalence, then there might be like, well, I mean, every once in a while I might have a little hangover, but besides that, it's a little tricky. And I think people have different views on using that because we want to be authentic as well. And so if we come across as being gamey, that can hurt rapport and engagement. But I've also seen people be able to pull that off in an authentic way. But it's definitely the same construct as evocation. I try to use motivational interviewing with my teenage children that are my own children. And I would find that technique too risky with them. So I think, yeah. Have you ever tried it, Tim?
Yeah, I tried it a lot in corrections, especially with people who don't want to be seen as weak going to mental health services in the correctional institution. So them being there and sitting kind of disgruntled, you could kind of not be, like you were saying, trying not to be, I'm not trying to deceive anybody, but ultimately kind of play it up into their head like, so you really don't. So this is kind of a waste of everything's going fine then. And then just wanting to find those little breadcrumbs. And I've had some success with it. I just was curious your opinion on it. I appreciate the feedback. Thank you.
Thank you. Any other thoughts or questions or ways you've applied this in your own work? Well, I went faster than I meant to, Brandy.
That's okay. This was great. I think for me, it's always a nice, kind of reminder that, oh yeah, I continue to, move in the right vein, and, clinically I'm using these things routinely, and that it's second nature. And yeah, I do see the, the positive effect of it, so that
Yeah.
was great.
Thanks again. I was going to ask you and Dr. Fink in my education, motivational interviewing, and you mentioned this earlier, grading transcripts or coding transcripts seem to be the way that you really kind of got it. I mean, do you have any suggestions on, does Mint have transcripts that you can, or videos that you can look at, anybody can look at, and then try to do some recording, some coding or those kind of things?
Yeah, that's a great point. Like anecdotally, I totally agree with you. That's when it really gelled for me, was getting in coding. I don't think there's a fair amount of research on what it takes to effectively teach people to do motivational interviewing. So we know that while didactic seminars like this can help to lay the foundation, if people actually want to put it into practice, it takes the opportunity, you have to apply it and get some feedback, whether that's from actual, coding of your real sessions or even through role plays and skill-based seminars. But where Brandy and I used to work, CASA, the Center for Alcoholism, Substance Abuse, and Addictions at the University of New Mexico, I'm going to share screen. Am I sharing screen? Tell me if I'm not. Has these tools, one of the kind of the gold standard and pretty easy to learn and use is called the Motivational Interviewing Treatment Integrity Code. Even just reading this manual, I think, is a good exercise in learning motivational interviewing. They have global scores that kind of map onto some of these constructs that we've talked about. And then also like sorry if I'm making everyone nauseous, behavior counts that you can tally up. You can code your own sessions and give yourself feedback. But on here they have these examples, audio and video examples of motivational interviewing that you can go through and practice code. And then they even give you the cheat sheet of what their expert coders found. In my past life doing clinical trials, when I wanted to train the study clinicians up they would need to have high fidelity in motivational interviewing, obviously, before they were being a therapist in a trial that's supposed to test the modality. But this was a common exercise that we would have them do on the path to.
Guys, that's a great resource. Would you mind copying that link and putting it in the chat?
Heck yeah.
Thanks again. Very nice.
There's also an organization called the Motivational Interviewing Network of Trainers. So if you're really into motivational interviewing and want to take it to the next level and learn strategies for training others, it's a really fun group, and there are annual forums all over the world. And it's really a great way to stay up to date on the emerging science of motivational interviewing. It's kind of fun training in motivational interviewing because there's a lot of parallel processes between using motivational interviewing clinically and training motivational interviewing. You guys are, we're preaching to the choir, but like Tim described, I've trained prison guards to use motivational interviewing, and you can bet that they have a lot of ambivalence about whether or not this is a modality that belongs in a prison setting. And so you, in the context of training, are doing a lot of listening and empathizing and strategically drawing out their change talk about wanting to have more effective interactions with the people that they're working with. Okay. Well, thanks so much for having me. Good to see you.
Yes, thank you, Dr. Hedeman. This was just great. It was so nice to see you today, and just hope you're enjoying your time at LifeStance, and we need to take a moment and catch up with each other.
Sounds good. Thanks, everybody.
Okay.
Bye.
Yeah, thanks. Bye-bye.
Thank you very much.